Thank you very much. Go ahead, Roy.
Okay. My talk will be about the long-term care of the locked-in syndrome, including the results of my prevalence study. That's already an older study. Some background I will go through really fast. LiS is characterized by preserved consciousness. There are three types, which are shown here. Classic LiS is defined by quadriplegia, unable to move, anathria, unable to speak, vertical eye movements and blinking. Partial LiS is the same as classic LiS, but with remnants of more voluntary movement besides the vertical eye movements. In total LiS, there is total immobility, including all eye movements. Vascular pathology is the most frequent cause, a stroke or non-hemorrhagic stroke. In most cases, a bilateral ventral pontine lesion is present, which means it is on both sides in the front of the pons. The pons is the part of the brainstem where the nerve pathways from the left and right sides of the body cross. Mean time spent in LiS is 6 years. Mortality is high in the first 4 months due to pneumonia in 40% of the cases. Recovery of speech and voluntary movement is possible, and significantly motor recovery is reported within 3 to 6 months after start of early and intensive rehabilitation. Diagnosis is usually made after approximately 78 days, and a family member is first to realize that the patient is conscious in 55% of the cases. Confounding with disorders of consciousness is possible if vertical eye movements aren't discovered, which could lead to misdiagnosis. The different types of disorders of consciousness are shown here. Unresponsive wakefulness syndrome is the new name for the vegetative state. Before the study I did and my colleagues, we didn't know the prevalence and characteristics of classic LiS in Dutch nursing homes. We still don't know the survival, quality of life, the patient's will, and end-of-life decisions. Currently, we have more than 1,000 long-term care organizations, including nursing homes, residential care homes, and home care, which provide long-term care in more than 180 nursing homes, with an estimated 72,000 total beds at the time the study was conducted. These nursing homes are specialized in somatic and psychiatric long-term care. Professional care is provided by multidisciplinary teams led by a nursing home physician specialist like me. We are trained in a 3-year specialist training, which only exists in the Netherlands. What is a nursing home physician specialist? Working in nursing homes makes unique demands on problem-oriented working methods, medical knowledge about chronic conditions, such as acquired brain injury and, of course, LiS, and presentation of illness in vulnerable nursing home populations, communication skills, multidisciplinary cooperation and organization, and dealing with complex medical ethical dilemmas. The nursing home physician specialist combines the competencies of a general practitioner with a geriatrician. Our objectives in this study were establishing the prevalence in Dutch nursing homes and the patient characteristics. We conducted a cross-sectional study in all Dutch somatic nursing homes. Inclusion criteria were quadriplegia, anaphria, vertical eye movements, or eye blinking on request, and a pontine lesion detectable by MRI or CT. Exclusion criteria were the presence of voluntary movements beyond the eye movements, total absence of vertical eye movements or eye blinking, and the absence of a pontine lesion. The study was assessed by the local research ethics committee and did not require ethical approval because no medical scientific research was involved. The survey was carried out with informed consent of the patients, non-verbally expressed in the presence of a family member or the treating nursing home physician specialist. Here you see the flowchart of the research design. 187 organizations were contacted with a response of 91.4%. 11 organizations reported 12 patients. 4 patients died before reference date. 12 questionnaires were sent and completed. 2 patients were in a vegetative state and 10 patients were in LiS. 1 patient, however, was admitted to the nursing home after reference date and was excluded. In total, 9 LiS patients. Only 2 patients met the criteria of classic LiS. The other one were in partial LiS. The patients with classic LiS are highlighted in green. Both female patients, 35 and 53, were admitted from a rehabilitation center. This was caused by an ischemic stroke in the first patient and a vertebral dissection with secondary basilar thrombosis in the second patient. A dissection is a tear in the wall of an artery, specifically in the inner layer, allowing blood to enter and separate the inner layer from the artery wall. The loose part of the inner layer may narrow or block the artery and restrict the blood flow. A basilar thrombosis is an occlusion of the basilar artery, the main artery supplying blood to the back of the brain. The vertebral dissection was probably caused by neck manipulation after treatment by a manual therapist a few days before the event. All patients had a percutaneous endoscopic gastroscopy. The duration was calculated for the present nursing home stay. Patient 1 was admitted to the nursing home 4 days before reference date. Patient 1 only responded with yes or no using vertical eye movements or blinking. Patient 2 used a letterboard for communication on which letters are listed, and through vertical eye movements or blinking, she indicated a particular letter. We found 2 patients with classic LiS, and the total number of the somatic nursing home beds was approximately 30,000, which leads to this very low prevalence. We had 2 hypotheses for this low prevalence. LiS patients may live outside the nursing homes, receiving home care, or the Dutch practice of end-of-life decision-making, such as euthanasia or withholding or withdrawing artificial nutrition and hydration, may have led to this low prevalence. In a Dutch study performed by Peltz et al. To define the target population of brain-computer interface neurotechnology, 30 patients with LiS were found to be living at home in 2015 with substantial impairments that required intensive care. One possible explanation is the need to be in control of their lives and the support of dedicated partners and other family members who care for them. Another possible explanation is that they have a personal budget which allows them to choose who the care provider is and how the care is delivered. Availability of and access to specialized long-term care in nursing homes is often unclear. LiS patients are conscious and legally competent. They have the right and capacity to make healthcare decisions for themselves, including euthanasia. According to the study of Brunner et al., the majority is happy and the minority is unhappy. For this minority, LiS might be a cause of suffering, which may lead to a request for euthanasia, which was highlighted worldwide by the rejected request by the English patient Tony Nicholson. In the same study, 7% of the French patients expressed a wish for euthanasia. However, euthanasia is legally not allowed in France. Euthanasia in the Netherlands is strictly regulated by law and is only possible if certain due criteria are met, which are listed here. SCAN, which stands for Support and Consultation in Euthanasia, the Netherlands, is a program in which physicians are trained to advise efficiently and independently colleagues who receive a request for euthanasia. Euthanasia is performed according to guidelines. However, euthanasia in patients with LiS is rare, since only 1 case has been described in the Netherlands. Contrary to the beliefs of many healthy individuals, patients with LiS self-report a meaningful quality of life, and the request for euthanasia is probably uncommon. Patients with LiS may regain a productive life and become active members of society, with Stephen Hawking as a good example. They may also return to live at home and can start a new, different, but meaningful life. Stephen Hawking, a patient with LiS as a result of ALS, solely communicated through a computerized voice. He was a brilliant physicist who wrote the bestsellers A Brief History of Time and the Universe in a Nutshell. This is called a disability paradox, which means that people with severe and long-term disabilities report that they experience a good or excellent quality of life, even if to most external observers, these people appear to have an undesirable existence. Analyses of interviews revealed that quality of life depends on several factors. such as still having control of their bodies, minds, and lives in some physical or mental ways. They demonstrated a can-do approach to life. Quality of life also depended on establishing and maintaining good relationships in the patient's environment. An example was Wim Tusveld, a Dutch patient with LiS as a result of a brainstem stroke. He was completely paralyzed, and yet he scored his life with a 9. He said that he did not focus on things that are no longer possible, but on things that still are, such as painting. Information on LiS is sparse in long-term care. According to a Swedish study, motor functions can still improve several years after stroke. Patients with LiS reported unfulfilled needs, which are listed here. Sometimes they were forced to find aids and organize follow-up on their own with one participant and a proxy the attention to write a book about it. The same participant also found this information and support by becoming a member of a patient association. I will conclude this presentation with the following recommendations. It is important to increase the awareness of the long-term consequences of LiS by involving experienced experts and different forms of media, such as books. Also, more information and support by professionals. In the Netherlands, there is ENA-COMA, the Expertise Network Severe Acquired Brain Injury After Coma, which develops and shares knowledge about severe acquired brain injury. They do this for professionals who are directly or indirectly involved in care of people with severe acquired brain injury, but also for loved ones, referrers, and anyone who wants to know more about this. The webpage of ENA-COMA can be found at the bottom of this slide, and it is in Dutch and English. Enhance quality of life, particularly social well-being, by actively diagnosing physical and or emotional problems and discussing treatment options and end-of-life decisions. Are there any questions?
Thank you, Roy. That was a very interesting and comprehensive coverage of what is available and how people are treated in the Netherlands. I know that we've got several locked-in people who are in the Netherlands, and I'd be very interested to hear their experience of the medical system there and how their ongoing treatment is continuing. Is anybody online at the moment in the Netherlands? Dick, perhaps, are you here? Dick's the composer of the music that we've had at the beginning and the end of our webinars for the last couple of years. He's very talented, and I know that he's living in the Netherlands. Does anyone else have questions for Roy? The group chat's still open, so if anybody does think of anything, please post it to there and Roy can answer you. And he's kindly given his email address, so if you want to take a screenshot of or a photo of that, then you can contact him at any time, or again, as I've said many times before, you can reach anybody through me at my Brain Foundation email address. So thank you very, very much, Roy. It was good to meet you. Thank you for coming to see us today. And I think that perhaps, do you have anything further to add?
No.
Thank you, Roy. Good to have you with us.
Can I ask a question, please?
Yes, you can, Phil. Hello, Phil.
Yeah, okay.
I recognize your voice straight away. Good to have you back.
Okay, thank you. Roy, that was a very interesting presentation. Thank you very much. The question I have is, what happens with prosthetics? Let's say more movement recovery occurs or speech is restored to these people. How do you think that's going to, how is that going to be interpreted?
Yeah, that's a good one. If speech should recover, then you could say then someone is locked out because he's able to communicate again. Yeah, that's a difficult one.
But it would make a big difference in their lives to be able to say, use their right hand to type or to speak to a computer.
And the problem we have in the Netherlands is it's mostly the insurance companies. I had last year I had a discussion with a rehabilitation physician. He had 3 patients with LiS, and he wanted to rehabilitate them. and recovery begins mostly after 3 to 6 months. But the problem is in the insurance company says, yes, but a stroke, if you don't see any recovery in the first 6 weeks, then you should stop the treatment. But people with LiS, however, are different. And we try to make those insurance companies clear we have to continue the rehabilitation, because everything they each recovery, if it is a voice or the use of a hand or a finger, can give them more possibilities to communicate. And that's one of the reasons people leave the nursing homes, because I have met some patients on the Patients Association. That was Wim Tusveld and some other, and they said the same. Rehabilitation physicians say this is it. It won't recover any longer, and then they go at home disappointed by care themselves, including recovery. They do it themselves, and then you see in months and years that there is recovery.
But
so I think we've seen that repeatedly. Sorry, Jane. Sorry, Phil.
So yeah, you have with locked-in syndrome, you have to rehabilitate much longer than in any other situations, for example, stroke. So you need to take the time.
Are you saying that the insurance companies would stop paying if there was some recovery?
No, the problem is they perceive locked-in syndrome as a kind of stroke, and in most cases of stroke, if there is no recovery within 6 weeks, you have to stop the rehabilitation. And in most cases, there is recovery in 6 weeks. But what they don't know is that LiS is different than those stroke cases, so you have to rehabilitate longer. And we try to, they don't have the knowledge about LiS, and that's the problem. If they pay for the rehabilitation, then rehabilitation physicists were able to rehabilitate much longer. And that's the problems they have.
Right.
Yeah, it is a very long-term problem.
Yeah,
I think the Sunas Clinic in Norway also have the same problem. Things just take a very long time and a huge amount of effort.
Yes.
Any further questions, anybody? Okay, thank you so much, Roy. It was good to meet you.
Thank you.